So now we're going to finish up with biliary disorders, and I'm anticipating this video may be brief. We'll see. So when we talk about biliary disorders, we're really referring to disorders of the gallbladder and the bile duct. I just am showing this picture again so you see the relationship between the pancreas, the spleen, liver, and gallbladder and the cystic duct and the common bile duct. You can see how they're kind of related, connected here, and how the gallbladder's nested within the liver. So I just want to call that to your attention, so just have a frame of reference. So really, when we talk about the gallbladder and diseases of the gallbladder, typically that's a result, most commonly a result of cholelithiasis or gallstones. And you have a couple of different types of stones, and there are a couple of discussion. There's a little bit more discussion about that in Figure 44.2 in your book, and then also some risk factors in Chart 44.1 in your book. So feel free to reference that. What I want you to take away from this is basically you have stones, and they're either pigmentation stones or cholesterol, and sometimes it can be a combination of both. It's not necessarily one or the other. Cholesterol can contribute to the formation of pigment stones, and cholesterol can become pigmented. I'm just going to show you some pictures and illustrate that. Essentially what happens, you have to remember that we talk about bile, you hear people talk about bile salts. And when we were referring earlier to the breakdown of the constituent elements of our food, some of the byproducts of that are we're going to break stuff down to carbohydrates, proteins, fats, and then there's also going to be the breakdown of sodium and potassium, and those electrolytes can form salts, and some of the constituent elements of our food can produce salts that basically constitute bile salts when combined with these other waste products. And when you remember, if you think about salts as we see them are a crystalline structure. So they're a little salt crystal. And if you have a structure chemically that becomes more stable in a crystalline form, then if it has a place where it sits and is allowed to be stationary or static, then they're gonna accumulate and form larger salt crystals, and they're gonna attract other adherent molecules and form what we would refer to as a stone. So obviously, depending on the severity of the stone or the cholelithiasis is going to depend on the severity of symptoms and the presentation of symptoms. They can be anything from none. People could have gallstones and have no symptoms whatsoever, or they can have severe acute or chronic symptoms. Usually that's going to be pain in the right upper quadrant, the right flank pain. It may also show up as a colic type presentation and nausea, vomiting. So I had a friend who his biggest symptom was he was just nauseous all the time. He threw up a lot, maybe some pain, but it was the nausea and vomiting that really caused him to seek care. So you can have some of that or all of that. Commonly relieved positionally or temporarily with medications, but not permanently. Now, if this progresses and becomes severe, basically what you've got is a blockage, an obstruction of the exit system for these waste products. And I think I've alluded to already what happens when I talked about obstructive liver failure, obstructive jaundice. When you have obstruction of the cystic duct or the common bile duct, this big junked up gallbladder, basically the liver is going to look like it's failing. So the patient's going to have elevated liver function tests. They're going to have jaundice and discoloration. The difference between this and chronic liver failure is once you relieve the gallbladder problem, either the gallstone occluding the duct or remove the bad gallbladder, then the patient's color and symptoms improve. So the changes in urine and stool color are the changes to this jaundice color. Everything has this kind of orange yellow color to it. They may also show a vitamin deficiency, typically the fat-soluble vitamins A, D, E, and K, because the liver is having trouble processing fats. And there'll be a variety of diagnostic tests. The most common is going to be a gallbladder ultrasound that's going to be most commonly diagnostic. This is what that looks like when you have cholesterol stones and pigment stones. So if you notice, the pigment stones really are all black here on the right. The cholesterol stones have a whiter color, but you notice how they do absorb and obtain some pigmentation. So at some points, it may be hard to know on the front end whether you have within these pigmentation stones, cholesterol stones that have just have absorbed pigment over time, pigment being the discoloration from concentrated bilirubin. That's what's causing this very, very dark, almost black color. Because if you'll remember, the biggest contributor to bilirubin is the breakdown of the byproducts from the breakdown of red blood cells. That's a normal biologic process, but if you break red blood cells down, you put it in a place, they'll tend to be brown. But if they concentrate and concentrate and concentrate, eventually it gets dark enough, it's black like this. So that's what those look like. And you fill up this one on the left is a gallbladder that's full of gallstones there, so you can understand why that needed to be removed. Now, how we're going to treat this, if we have gallstones that are occluding either the cystic duct or the common bile duct, and we have to go after them, we'll do a procedure called an endoscopic retrograde cholangiopancreatography. So basically, we're going in and looking into the gallbladder pancreas supply and drainage system, which is looking at primarily the cystic duct and the common bile duct. Depending on where the stone or stones are occluding, depends on how far we go. But commonly, they'll go in and clean out that whole duct from the common duct back up through the cystic duct into the gallbladder, and maybe even sweep the gallbladder while they're in there. And I'll show you a picture of what that procedure looks like here in just a minute. One of the main interventions here is going to be eating a diet that is more conducive to digestion. So we'll start these patients back on a full liquid diet, and then encourage high quality foods such as fruits, vegetables, leafy greens, salads, all those things that we associate with a good diet, and trying to decrease fatty foods, particularly processed and deep fried foods, because those things definitely contribute to the symptoms or to these problems. High salt foods will also reduce. There are a couple of medications that you may see administered with cholelithiasis, and that's ursodeoxycholic acid and quinodeoxycholic acid. Those two drugs you may see ordered to help with the management of gallstones. These acidic these acidic drugs help minimize the formation of gallstones. And you may also see if an ERCP is ineffective, if we can't remove stones from the gallbladder with an ERCP that's not invasive or relatively minimally invasive procedure, or from the duct, then we may have to go in and do a cholecystectomy. And you can see a laparoscopic cholecystectomy, or you can see an open cholecystectomy, depending on how severe and how distended that gallbladder is. This is a picture of what the ERCP procedure looks like. You can see the stone here occluding the duct. In this case, a T-tube has been placed. But what they've done here is they've accessed the common bile duct through the duodenum, and they go in through this tube and advance a basket over that and then come out. No, we don't advance the basket that way. We go in through the common bile duct. Yeah, like this picture right here through the duodenum. We come in through the cystic duct, past the pancreatic duct into the common bile duct and remove the stone, as you see here, through the sphincter of Oddi. This is what I was referring to earlier. So this is how we go in, and you can use a basket to retrieve it. What you will also see commonly done first, if we can avoid using a basket, we'll take the device up that has a balloon in it and advance the catheter past the stone to this area and inflate the balloon, and basically use the balloon to pull back and drag the stones back into the duodenum through the sphincter of Oddi. So apologize for that little bit of confusion there for a moment. So that's how an ERCP works. Then laparoscopic cholecystectomy, you see an image of them performing the procedure here. So several small punctures, they go in and visualize the gallbladder. They have a couple of dissectors that they go in and dissect tissue. And when they're ready, when they've done sufficient dissection and ligation of the cystic duct here, then they will use the retractors to actually pull the gallbladder and associated structures out through this insertion point. Now, depending on the size, if it's large and they're having trouble, then what they may end up having to do is break it up into pieces. And then if that's the case, then they're going to do a washing here. Now, definitely want to do a good ligation before removal, because we'd like to not empty all of this gallbladder fluid, this bile, into the peritoneal cavity. So nursing care, what does that look like? Obviously, patient history, connected to the signs and symptoms and associated presentation with this current report and this admission. So we want to explore, think of old cart here. What caused this to start? When did it start? How long has it been going on? What are symptoms that exacerbated it or relieve it? Has it been persistent the whole time? What's the character? Does it ameliorate and then worsen? All of those questions. And if there's any history of gallbladder issues in the family, we assess the knowledge and education needs. How do they understand what's been done? Help them understand the function of the gallbladder and its absence in this case, and why dietary adjustments are going to be so important, and good nutrition is going to be critical. So that the liver can operate efficiently, because it doesn't have that gallbladder anymore to manage that process. Those processes will be immediately dumped into the duodenum. We definitely are going to be monitoring for bleeding, of course, and then monitoring any gastrointestinal system symptoms, nausea, vomiting, loss of appetite, gastric distension, fever, because we are manipulating things in and around the peritoneal cavity. So leaks are possible, and leaks can lead to peritonitis. So we want to be attuned to those kind of symptoms, such as fever, distension, hypotension, that sort of thing. I've already mentioned bleeding and GI symptoms. Now, occasionally, more so from open chole than from laparoscopic chole, do you get conditions like atelectasis, which atelectasis is referring to collapse of portions of the lung. So when patients are opened, sometimes their bellies are sore enough that they don't want to take deep breaths, and that can create atelectatic portions of the lung. They aren't taking deep breaths. So as I've mentioned before, with just about any patient, turn, cough, deep breathe. That deep breathing is important to maintain lung function. And depending on mobility and how they're feeling like moving around, if we're not able to get them moving, thrombophlebitis, of course, can be a risk. And as we said when we were talking about PEs and DVT formation, thromboembolism prophylaxis is a staple now of hospital care, and we want to keep these people moving so that we can help prevent thromboembolism development. We've actually covered this already. As far as positioning goes, typically have the patient in a low Fowler position, but their head of the bed can be higher if it's more comfortable for them. Maybe NPO until bowel sounds return, and then usually and possibly even a liquid diet until about, at the beginning, and then a soft, low-fat, high-carbohydrate diet, because those carbohydrates are going to be easier to metabolize. They may or may not have an NG tube. So I have that note is here. May not necessarily be there, but often they will, because we would like to know that despite the surgery and surgical intervention, things are moving through the gut and not accumulating in the stomach. And we certainly don't want these patients aspirating. The analgesics become important here, not only for patient comfort, but so patients are deep breathing, right? I mentioned earlier, turn, cough, and deep breathe, using a pillow to splint the abdomen when they cough to help facilitate a good cough, clearing secretions, and taking those deep breaths. And we definitely want the patient up and moving. And as with just about any condition, we're educating. So those are the key things with gallbladder issues, and thank you very much.